Good afternoon, everyone, and thank you for once again attending the California Black Health Network's Health4Life Series on diabetes. I'm Rhonda Smith, the Executive Director of the California Black Health Network, and again, thank you all for attending today. And for all of you who have been consistently participating in this series, I'm sad to say that today is the fifth and final version in the series of Let's Dismantle Diabetes. Today's session is focused on diabetes prevention and how to control the controllable. And so we'll focus more specifically in this session today on understanding what you can do to prevent diabetes, what are the controllable risk factors, and what actions you can take to actually take control of your health and well-being, as well as prevent diabetes. Or if you're managing your diabetes health condition, what can you do to prevent disease progression from occurring? And so once again, we have with us Courtney Walker, who's the Health Equity Outcomes Director for Novo Nordisk. Before we start the program, as per usual, just a few housekeeping items before we hear from Courtney. Just want to make sure that everybody puts their questions in the chat, so you'll have an opportunity to ask questions of Dr. Walker after he finishes his talk today. You can say hello and put some chatter in the chat. I've seen some folks say hello and thank you for doing this, and you're welcome. I'm happy that you are finding value in the information that we're sharing and what you're learning from this series. Everyone will remain on mute and off video. And before I turn it over to Courtney, just a few slides or information about CBHN for those of you who may be new to the session today. So the California Black Health Network is a 40-year-old organization. We turned 40 this year, and from the very beginning, we've always focused on improving the health and well-being of Black Californians. And our vision is to create a California where every African-American and Black immigrant has the opportunity to live a long, healthy life that's free from violence, racism, and health inequities. And we do that every day through our mission to ensure that all Black Californians, regardless of their education, social and economic class, where they live in terms of their zip code, their sexual orientation or identity, or housing status or immigration, really has the opportunity or access to high quality, equitable, primary, as well as behavioral health care. And so today, our speaker, once again, is Courtney Walker. Mr. Walker or Dr. Walker is a great partner to work with. And again, I'm sad that this is the last series, but I know we'll see each other again. But as I mentioned, he is the Health Outcomes Director for the Health Equity Division of Novo Nordisk. In this role, he is a subject matter expert and the primary point of contact for all external health equity champions that work with the managed market accounts. He was previously the medical account director at Novo Nordisk and covered the Texas, Arizona, New Mexico, and Las Vegas region, focusing primarily on diabetes and obesity. Dr. Walker is a proud graduate of Texas Southern University's College of Pharmacy and Health Sciences in Houston. And upon completing his degree there, he actually worked in managed care pharmacy residency at Humana and a host of other organizations before joining Novo Nordisk. So I think he's about ready to begin. So I will turn it over to Dr. Walker for him to share with us his words and message for today.
Rhonda, thank you so much for that kind introduction. And I also would like to thank the California Black Health Network for this opportunity, these 5 opportunities to present this Dismantling Diabetes series. It has been enlightening, it has been fun, and also I think it's something that we can replicate as well. Ironically, I may get the opportunity to do it in the LULAC organization, in the Hispanic community, and it's all because this was the standard. And so thank you again. And certainly I look forward to maintaining connection with you guys because I just think it's so very, very important. Rhonda, can you see my slides?
Not yet. I know you got that high-tech setup over there.
What about now? Can you guys see them now?
No,
Oh, yeah,
not yet.
it said, are you
Okay,
sure you want to do it? Yeah, hold on a second.
okay, great.
Should
All
be,
right, it's your
should
show.
that, is it there? Is it
Yes,
showing?
we can see it now, yes.
Excellent. Okay. So again, thank you again. And this is just this has been great. It's been an awesome five part series. And just to kind of do a recap, you know, we first started talking about dismantling diabetes, the why, right? Where we delved into the issue of diabetes in the African American community, specifically even going back, talking about the impact of slavery and Jim Crow and access to food sources. And it's very important for us to consider the impact of our very unique past and why that has so much to do with where we are now. Next part, we went to this no sugar baby, where we talked about specifically African American community, our grandparents and the matriarchs and patriarchs of our community basically talked about diabetes as sugar, you know, and didn't talk about it in a way where there was a complete understanding of the disease. And that certainly also has impacted how the disease has proliferated the way it has and impacted us in such a negative way. And so we went a little bit deeper in that conversation. Thirdly, we talked about treatment, treating versus treatment, how to look at treating type 1 diabetes, the impact of insulin, type 2 diabetes, the impact of diet, exercise, the impact of oral medications versus insulins, injectables, the impact of that in the community, and just really talking about that. And then fourthly, diabetes equity and access, why where you live matters. And what we know is when we take in consideration the impact of that, it's extremely impactful on patients and the disease. So that's certainly been a part of the conversation as well. Then lastly, today is about diabetes prevention, how to control the controllable. We're going to talk about the difference between modifiable and modifiable risk factors. There are risk factors that are modifiable. You can change them. You can do something about them. And then there are those risk factors that are non-modifiable. You can't change them, but what can we do to contribute to resisting or preventing diabetes, which is the ultimate goal, right? You know, if we can prevent the disease from coming, then we certainly can live high quality of life situations where we actually have a high quality of life. So going back to some basic statistics that we've talked about, and you know, I don't have a lot of slides today. But I think they're poignant just to bring up conversation as we talk about the key to prevention. Again, the problem is that in the African American community, which represents 13% of the US population, when we think about when we look at diabetes numbers, you know, Black Americans are 50% more likely to have type 2 diabetes. What we know is specifically that the risk of death from diabetes is going to be higher in Black Americans, 2.5 times more likely to die from the disease than white Americans. So you're talking about disproportionate mortality rates in the African American community as compared to the white community. And so specifically, any statistics that are like that are something that we definitely need to look at and figure out why is there such an increased susceptibility, which has just negative consequences that can lead to death. And so, and then what can we really do about it? And then again, you're talking about 37.3 million in 2019 people had diabetes. 96 million people over 18 years old had pre-diabetes, which is this relationship between increased weight, because whenever you see pre-diabetes, remember we talked about pre-diabetes correlates to obesity, which correlates to increased insulin resistance, which then correlates to type 2 diabetes. What we know is that type 2 diabetes is a disease of insulin resistance and insulin deficiency. Insulin resistance correlates to weight. So we know weight has a very, very important impact. So when we talk about prevention, we're going to talk about reducing weight so that weight insulin resistance specifically is not an issue, thus putting you on the runway. Because whenever you hear pre-diabetes, it's always about the runway headed to full-blown diabetes, lessening the likelihood that we get on the runway headed to full-blown diabetes. And then the prevalence of diagnosed diabetes by race and ethnicity in the United States is going to be 12.1%, right behind American Indians and Alaska Natives. So, and then Hispanics right after the African American community. So when you think about African American Californians, you know, we have to take in consideration really understanding the impact of the disease on African Americans as a whole, so that we can begin to build the bridge to be able to fix the issue. And then thinking about COVID-19, what we know is COVID-19, typically groups had higher risk of developing serious illness from COVID-19 if they were age 65 years or older, some they can't change, people who were in a nursing home long-term care facility, they were older individuals, and then those people who were severely obese or they had not controlled diabetes. So diabetes, when it's not controlled, makes you more susceptible to develop serious illness from COVID-19. And then you're more susceptible to other diseases that are microvascular and macrovascular in nature, which we can talk about if someone has a question on that. So that's important. And then what we know is, again, going back to this increased body mass index or increased BMI, insulin resistance is higher. And what we know is the risk of severe illness from COVID increased as well. The CDC reported that by 2021, the 78% of those who were put on ventilators, who died or hospitalized, were either overweight or obese. Okay. And then so you could also surmise that some of those individuals were pre-diabetic or diabetic. So getting the weight down is going to be a huge focus of ours as we talk about prevention and what we can do to prevent pre-diabetes from becoming diabetes and taking more responsibility for our health. So let's have this conversation about modifiable and non-modifiable risk factors. We're going to go through and kind of talk about each of these risk factors. When you think about physical inactivity, is that modifiable or non-modifiable? It's definitely modifiable. We can be more active. We can exercise. We can walk. We can lift weights. We can do those things to move our bodies to physically help get that sugar to get out of our bloodstream that we're consuming and get into our cells. Obviously, we know there's genetic predisposition for a lot of individuals, but there's something physically that we can do to try to fight off and prevent from going into type 2 diabetes. So we need to encourage physical activity. That is modifiable. First degree relative with diabetes, that is non-modifiable. Can't do anything about that. But what we can do is there should be greater awareness if we know that diabetes, as they say, runs in our family. And when we know that a first degree relative with diabetes has had it, a parent, a grandparent, then certainly that means that we need to be more aware that there's a possible susceptibility to that. Number three, high risk race or ethnicity. Can't do anything about your race, can't change it. So in light of that, we need to be aware that high risk race, ethnicity, that is pretty significant when it comes to being aware that the fact that being African American, that being a part of our background, that's something that we need to be aware of. Okay. Gestational diabetes. If you're pregnant and you go over the line and you have gestational diabetes, then that gives you a greater likelihood to develop type 2 diabetes later on in life if you have that. So if you develop gestational diabetes or you had it when you were pregnant, it's certainly something that you need to be aware of. Your HDLs, your triglycerides, your cholesterol numbers, that's modifiable. You can do something about that. A cleaner diet, medications, possibly hypertension. You can treat your high blood pressure, being aware that say, hey, you know, I'd like to lower my blood pressure, lower my cholesterol. That's important. A1Cs, you know, certainly having a higher A1C over 5.7%, that's a diagnosis of leading towards a diagnosis of type 2 diabetes if you get to 6.4. Severe obesity, something that we can do about it. Working on our history, the physical factors, So that's extremely important. Lowering your weight, acanthos nigricans, something in African-American kids to be aware of. Is there a darkening around the neck, or are there little mole lesions on the backs of kids? They're doing more and more checks because now you're seeing insulin resistance. And these are signs of insulin resistance that we're seeing in younger and younger people. And so the screenings are taking place in schools now to be able to be aware of that. And for women who've had polycystic ovarian syndrome, this is certainly something to be aware of as well. That is a precursor or a predictor that type 2 diabetes might be an issue later on. Non-alcoholic fatty liver disease, we're seeing that more so. Can you do something about it? Diet, exercise are important to fight that off. History of cardiovascular disease, understanding the family history, and doing everything that you can from a genetic predisposition to minimize the likelihood. That's diet, that's exercise, that's smoking, limiting smoking, not being a smoker, because that increases your risk of cardiovascular disease. Age 45 years without other risk factors. Nothing you can do about it. But once you go over 45, you need to be aware of, hey, there's an increased susceptibility. Antipsychotic therapy, being aware that if you're in need of those medications, that there's a higher risk. Chronic glucocorticoid exposure, understanding that when you get those steroids, that they help with inflammation, but there's a risk associated with that long term that could lead someone into a diabetes diagnosis if it's too much. And not being aware of that. And then sleep disorders, getting more rest, getting more sleep, or taking medications to help you rest. Doing what we can through our risk factors to prevent going into type 2 diabetes is extremely important. And we talked about this too, nutritional considerations, being able to realize that nutrition is going to be extremely important. Monitoring your carb intake, fruits and vegetables, lowering your caloric intake, understanding what your basal metabolic rate is, and trying to eat at or below that to ensure that weight, you're not headed in the direction of prediabetes or weight issues. Being aware of dietary fats, understanding what good fats are, avocados, good healthy fats, omega-3 fatty acids, fatty fish at least twice a week, that work towards lowering cholesterol and helping you move towards being as healthy as possible. And then just having nutritional considerations that takes in consideration, hey, I don't want to proliferate into full-blown type 2 or type 1 diabetes. And then physical activity, at least 60 minutes of physical activity each day in terms of children with pre-diabetes, or if they don't have diabetes, understanding physical activity is extremely important. The scary thing is about in this day or time, it's not like when I was a kid, when it was basically everybody played outside. I can remember as a kid during these summer days, we played from morning to night. You either worked or you played, and you came home for lunch. Then you went right back out and played, sometimes till the street light came on. You played out in the sun. You were very active, but it's not like that. We even had video games, but there wasn't a consumption with video games the way it is now. So understanding that that's going to be extremely important to reduce your risk and move towards prevention. Adults with diabetes, 150 minutes per week, and sometimes what you can do is lead towards remission through maintaining that moderate intense aerobic physical activity. So what the need is to maintain that, and to do that before time. If diet and exercise are part of your life, while you're healthy, in all likelihood, you won't go towards having a full-blown diagnosis of diabetes. And understanding that, as you understand, all these areas that we talked about have a role to play in prevention. Our family, our values, our culture, is activity, is proper diet a part of that? Are we in faith organizations that sort of facilitate that and talk about that? Are the schools encouraging that through the foods that are made available, or what we feed our kids when they go to school? In the communities, the neighborhood, understanding the environment and what we can do from to ensure parks and recreations, our kids are having fun and going and exercising and working out, and that we're walking and we're exercising, maybe riding bikes or something that we can do. And then being aware of the media, being aware of, all the fast food, advertisements that come on TV. We're going to talk about this in the next couple of slides. They have a real impact because it is a different world than what it was years and years ago. And then public policy. What can we do to support policy that moves us towards prevention of diabetes, healthier foods, exercise, activity, evaluating equity issues? Doing those things are going to be extremely important. What community organizations that are supporting a healthier African American community can we be a part of and listen to improve health outcomes and move towards prevention? And understanding that, again, access to quality care is really a small part. The biggest contributors are the 80% of a person's health is really about that social determinants of health or their personal ecosystem, which is their socioeconomics, their education, employment, social support, family, income, community safety. That's 40%. Physical environment's 10%, where individuals live, and that also is connected to the community, what food sources they have access to. One of my favorite movies, Boys in the Hood, when the dad was taking his son Trey, and he was saying he was looking at the community and looking at the liquor stores and looking at certain things in the community that contributed to negative health outcomes, and not having grocery stores. We have to continue to think about those things and continue to encourage the pursuit of healthy fruits and vegetables, and doing whatever is possible to move towards healthier diets, and controlling what we can control. Health behaviors, tobacco use, alcohol use, sexual activity, looking at those things that certainly can move us towards worsened health outcomes. That's going to be a huge part of personal responsibility in changing some of these outcomes. Because again, as I said earlier, it's not what it was. In the 1950s, the average soda was 7 ounces. Now it's 42 ounces. So how can we lessen the likelihood that we're drinking that much sugar, which is contributing to insulin resistance and contributing to obesity, contributing to type 2 diabetes? The average hamburger in the 1950s, 3.9 ounces. The average hamburger now is 12 ounces. Reducing the size. I try to eat junior burgers or eat turkey burgers, it's just healthier, right? French fries in 1950s, 2.4 ounces. Now they're 6.7 ounces, right? Lessening less understanding that supersizing has come with consequences, and had a negative effect on health. And then some of the other contributing factors: sleep deprivation, stress, physical inactivity, and then epigenetic modifications. All these factors contributing to obesity, which contributes to prediabetes, contributing to diabetes. So this is why it all sort of works together, and we have to be aware of that and make decisions to move. Hey, Rhonda, I want to stop and see, are there any questions or comments on kind of what we've talked about so far?
I don't see questions in the Q&A box, but Ambria, are there any in the chat?
No questions in the chat. Well, we just got one, and it is, what are some examples of fatty fish?
Oh, I mean, you can, salmon is a good fish, and it's full of omega-3 fatty acids. And so most fishes, will have, some are going to be healthier than others, but salmon is a great fish. You can, but some of the white fish are going to be different in concentration of oils. So halibut, swordfish is going to be white and flaky, not as much oil as the salmon, but those are fishes that can be really, really healthy in that regard. So yeah, salmon is going to be really good. And then also halibut, is another good fish. As I said, swordfish, mahi. Those are good cuts of fish. Now some of the bottom
Sure.
feeder fish, catfish, and then also tilapia, not as good as the salmon. So just to kind of keep that in consideration.
So can you talk a bit more about the role of omega-3? Like, what is that and what does it do for
Yeah.
someone?
So omega-3 fatty acids are just a certain type of um, uh, oil or fat, if you will, that are just healthier for the cardiovascular system. So is HDLs, and you've heard LDLs and HDLs have to do with the density of the cholesterol, if you will, the high density lipoproteins in the body. The HDL takes kind of cholesterol and fat away from the heart. LDLs takes fat and stuff towards the heart, contributing to accelerating heart disease. And so when you think about that, healthier fats or healthier oils that we take in could work in a similar way to the HDLs of keeping the heart healthy, taking the bad fats or the bad substances away from the heart. So therefore, the cardiovascular system can be healthier over time. So that's why it's good to understand your HDL. Having a higher HDL is going to be better. Having an LDL below 100 is going to be better. Having HDL numbers above your 50s, 60s, having higher numbers are going to say, hey, your body is functioning where it's taking as much as taking as much cholesterol and gunk away from the heart, and that's going to move you towards better health outcomes.
Great, thank you. And while we're on this slide, I'm really curious if you can go back yet. So I'm really curious about the role of stress and sleep deprivation in
Oh yeah.
the risk of diabetes. Can you go into that a little bit more?
Yeah, the problem with sleep deprivation is cortisol levels, which can contribute to weight gain. If you don't get enough sleep, your body doesn't, is not able to repair. So during we have repair and recovery time while we're resting. And if we don't allow ourselves to do that, then we're kind of fighting ourselves. It's kind of like, we live in a time where, now we have plug up cars where at the end of the day you plug your car up, and what's efficient is letting your car recharge enough so you can drive it the next day. And the human body ingeniously was kind of made the same way, that we were kind of created to lay down at night and sleep, and we rest, and during that time of sleep is where we rest and recover. And if we don't get adequate amounts of sleep, our cortisol levels can contribute to weight gain because we don't get enough rest. So sleep deprivation can be terrible. And there's a lot of individuals that think that lack of activity, sleep deprivation are the new smoking, in terms of just hazards to your health. So you need that rest. And then stress, your ability to handle changes. That's going to be a part of my last slide, where I talk about some of these stressors, identifying our stressors. And specifically in the African American community, toxic stress is associated with conversations of structural racism and generational issues. If you're born into generational poverty, that's more of a stressful situation. And so we have to think about the impact of toxic stress on our community and work towards coming out of that, so it's not an issue. So stress is huge, and understanding, so that's why social support, family structure, those things are huge. So, and don't forget physical inactivity. I mean, some of the if you guys go and you really want to study something that's interesting, study the blue zones. The blue zones are the communities around the world that has the greatest concentration of centenarians, individuals 100 years or older. And all of these individuals, guess what? They eat a lot of fish. They eat a lot of fatty fish. Some of them, they live right on the coast. So there's a lot of fish content in what they eat. They're extremely active. There's Osaka, Japan. There's a place in Italy,
In
Loma
Costa
Linda,
Rica. Yeah,
Costa Rica, Loma Linda, California, Costa Rica. All of these places are places where, you know, they get plenty of rest, less stress, eat plenty of fish, very active, and that certainly contributes to better health.
And I think also there's a social component. There's a lot of social activity also that's part of
Yes.
contributes to that. Yeah.
So social component is huge. Instead of living to eat, you know, you kind of eat to live. You know, there's more of a focus on that. So enjoying. I remember when we were in Rome a few years ago, we were at a restaurant, and they have these 2-hour siestas in the middle of the day, and we were completing lunch, and everybody disappeared. You know, and we were literally in the restaurant by ourselves. You know, there was nobody there because everybody took so seriously going home for 2 hours to rest, you know, in the middle of the day, you know. And I was like, wow. And my wife and I were like, there's no way this happens in the United States, right? Because we're more of a stress, you know, we're more stressed in terms of how we function. But I think we just have to understand some of the things that we need to do to move towards being healthier as possible.
Yeah. And so one of the questions is, like, you talked about inactivity, but how much daily activity would be recommended for adults?
Yeah, I mean, I would say, I mean, definitely we have these, you know, 150 minutes a week, or as I said earlier, I think it was 60 minutes of physical activity each day. But, you know, we have these jobs, like I'm sitting down right now, but guess what? I got a desk that I can raise where I'm standing, you know, staying as active as possible. One of the communities that I was talking about in Asia, a lot of the older individuals, they just keep active. The ones in Europe, you know, they have farms, or they're taking care of the animals, and you know, they're constantly doing something. So this is what we're talking about when we're talking about physical activity. Just maintaining, you know, good movement, and not just sitting there, not just being sedentary. There's a temptation in our time to do that, you know, and with games and this, that, and the other, it can be a problem. There's only 2 more slides I wanted to show, but I do want to say this, that we also, from a prevention standpoint, have to have relationships with our physicians that promote health equity and move us towards removing the barriers to ensure that everyone has the ability to reach their full health potential. And that means, you know, for the physicians to understand people first language across the board. And, don't use the language of vulnerable, marginalized, or high risk. You know, groups that have been made vulnerable, you know, something that contributed to it. Avoid dehumanizing language, you know, instead of, you know, people experiencing obesity or morbidly obese, you know, instead of, they're obese, they're fat, you know, in terms of how we talk. Remember that there's many subpopulations, people, you know, from racial or ethnic minority groups, instead of racial groups, or, you know, stigma and bias associated with just certain names. Avoid saying target, tackle, combat, or other terms of violent connotation. Say this: consider the needs of the African American population, the target population, instead of target population, and unintentional blaming. You know, say people with limited access, and understanding the responsibilities to the community that helps to contribute. Because again, if I go back to one of the main examples that I've used, is that the flower has so many different factors that contributes to its health: water, light, soil. And all of those things are really what contributes to the individual health of the said flower. It's not, we don't go blame the flower because it's not growing. We make sure it has everything it needs to survive. And so that's really where the conversation is. And then lastly, I know it says contributes to obesity, but again, you have to think about the precursor to type 2 diabetes is insulin resistance. And insulin resistance correlates to weight management. And there's these inside the person, outside the person factors that contribute to energy storage. So if I have energy storage issues where I'm taking in more food, more calories, but I'm not expending them the way I should, then what are some of the factors that affect that? And so all of these different factors are a part of some of the social determinants of health that contribute to the problem. And it can be environmental, pressures in physical activity, biological pressures on physical activity. It could be gut microbiota, physical disabilities, chronic inflammation, genetic, epigenetic factors, maternal development, gestational diabetes, as we talked about, economic factors, low socioeconomic status, nutrition support, the communities that we're in, are the foods that surround from a 5-mile radius. Are they mostly fried foods that surround where someone is living, where kids are living? I'm telling you, when you go do the zip code research, the less likelihood that they have access to a grocery store that has fresh fruits and vegetables. You can see higher BMIs, body mass indexes, more prevalence of disease, all of those things. So that's extremely important to understand. Food, beverage, behavior, how that, food security issues, family meals, lack of those, eating away from home, larger portion sizes, all of those have psychological factors, social anxieties, traumas, and then social factors, family conflict, weight bias and stigma, those things. All of these things have an effect. And so what prevention really is about identifying those factors and being able to figure out, okay, how can we move in a way where we lessen the likelihood to head towards some of those negative health outcomes. So I'm going to take the slides down and kind of, allow this to be the official time for questions, questions and more comments.
Yeah, I know you and I have had conversations in the past about obesity as a disease. And,
Right.
Earlier you talked about obesity kind of being one of the modifiable or controllable factors. But what would you suggest, or what are your thoughts about when it's not that situation, when it's, obesity is really more of a disease than a controllable factor? Like, how does that play into diabetes prevention? And what are your thoughts about that?
Are you saying when obesity is more of a non-controllable, that you can't control it?
Correct.
Oh, well, I mean, when you think about obesity as a non-controllable, I think I take a little issue with that from the standpoint of no matter if it's genetic predisposition, this whole thought process of being big boned, there's always something that we can do, right? There's something that we can do from a dietary standpoint, body, BMR, basal metabolic rate, your ability to process foods, your energy storage in and out, there's always things that you can do. But then when you think about surgery, when you think about the gastric bypass, the gastric sleeve, you're talking starting at 16% reduction up to 30% reduction of weight after those procedures. Now, those are not fix-alls. You have individuals that gain weight even after those procedures. But a lot of that has to go back to, is there emotional habits to the eating? Is there some, are we doing the emotional psychological support that could be contributing to the problem and why it's such an issue for the individual? I think, for all of us, if, the show TLC, My 600-Pound Life, I mean, every one of those individuals, when you sit and watch their story, it's complex. It's not simplistic. There's a lot of different factors that certainly can contribute to that. And I think, what good healthcare is to figuring out what the factor is and helping them move towards prevention. Because again, that's a part of it. But then the genetic predisposition is something that we have to think about as well. So I think the great thing about this opportunity, Rhonda, you've given within CBHN is to say, listen, we don't want just a simplistic view of diabetes. We want to look at is equity an issue? No sugar baby? All of that was strategic to say there's many different factors that are contributing to this problem, and we want to take the time to assess as best as we can.
Right. So, you said something that made me think about like what the whole reason why we're doing this Health4Life series and then different facets of health is, what we hope to create is a more empowered community of individuals who, are more health literate, take charge of their lives and be more proactive about their health and well-being. And so all the things that you just said are important, but they're not things that I think when you go visit your doctor or you have an exam or an appointment with a healthcare provider, that they have time to really get to know all of that about you or ask those kinds of questions. So what would you suggest someone does to make sure that, that information does get shared with their healthcare provider, or at least they know all these things?
And I'm so glad you said that, because that's a part of the social determinants of health issue of access to care, right? So access to care is a huge issue. And what our hope is that we have physicians that use person first language, that don't have the stigma and bias, and really are trying to help patients to get as healthy as possible. But let's be honest, it's hard for doctors to have the time to be able to address all these different factors. So if you got people who have a genetic predisposition, they eat bad, they don't understand the disease, doctors have a lot of work to do. So that's why organizations such as this, the American Diabetes Association, are trying to do as best a job as possible to educate community, so the community can understand the disease, can understand, why do we have the issues that we have from a number standpoint. It goes back to diet and exercise, smoking. I'm 47. I have a classmate, he's smaller than me, that had 2 heart attacks 2 days ago, but he smokes a pack of Newports a day, Rhonda. He's a guy I played football with. And diet, has significant impact. So when we talk about what we can do specifically, we've got to make better choices and better decisions, because better choices and decisions therefore can lead to better outcomes. And that's why the frustration of physicians are, hey, if I tell you what to do and you don't do it, so we have to continue to fight to do what we can on our end to address some of these issues and lessen the likelihood of going towards negative health outcomes.
Right. So you talked a lot about prediabetes. Are there any specific signs or symptoms of prediabetes that people should, be mindful of?
Absolutely.
Weight gain.
Weight gain is going to be number one. You're gaining weight. And then what I talked about in young people is acanthus nigricans, especially in the African American community, where they have a darkening around their neck, and then they'll have these little splotches or kind of moles or lesions on their backs. That's acanthus nigricans, and so they're doing screenings for those in schools now to see if there's a predisposition for diabetes diagnosis. Because remember, you get diagnosed type 2 diabetes, the time clock is heading towards microvascular complications. That means kidney and eye problems, and then ultimately cardiovascular nerve problems leading to amputations. So what we want to do is lessen the likelihood of going into some of those negative health outcomes from being the case. So being able to watch out for your weight, watch out for that darkening, and then the beginning of polyuria, polydipsia, polyphagia, which means a lot of urination. You have, problems with your body in terms of somebody asked about ketones. I saw in the chat, diabetic ketoacidosis, where you have ketone formation, you have excess sugar that's in your bloodstream, which pours over into your urine. Your urine will be extremely bubbly, a lot of bubbles in the urine, watching out for that consistently. Fruity smelling breath, which is another sign, that's saying that, hey, you might be headed towards type 2 diabetes, and it's something that you need to be aware of.
Okay, thanks. There's a question in the Q&A box, and I think there might be some questions in the chat, but we'll get to those in a minute. So this person says that they get their lab work prior to their physical, and their doctor and that this person compare trends. So
That's awesome.
they,
That's it.
they get printouts for future reference and status, et cetera. So yeah, I don't know if
That's it.
everybody knows you can actually get a copy of your lab results so that you know, and you're right. So you can keep track of how things may change over time. So if I don't know what you want to share about that.
No, I think that's smart. I think that's the way you do it. I think, you know, having your lab work prior to going to the doctor, understanding what some of the terms are. If you have a family friend that's a clinician that can help you understand, you know, there's this biblical scripture that says, "My people perish for lack of knowledge." What we don't know hurts us. You know, and I think it's so very true when you don't that's the whole essence, Rhonda, why No Sugar Baby was so important. And I think that's why you personally got a passion for it, because hey, you know, we just called it sugar and we thought, oh, I just don't need to eat as much cake. And it's much more complex than that. You know, it's not just backing off the cake and the sweets, but it's also helping my body use the sugar that I need. Remember, sugar is not the complete devil. Your brain uses sugar. Your brain uses sugar to operate and to function. Every cell of the body uses sugar. The thing is, we have gone overboard. Remember when I shared the example when I was in Europe and I had some ice cream and it wasn't sweet. And I was like, man, why is it not sweet? Well, they don't use high fructose corn syrup over there. High fructose corn syrup has a higher glycemic index, which leads us to a predisposition to predisposes us to higher sugar levels, which, you know, it's terrible, which leads us to, you know, more opportunities for hyperglycemia, higher sugar levels. So
yeah,
what
looks
we
like
don't know hurts us.
Great. So, right, ignorance is not bliss, right? So, looks like we have a few questions or at least some thoughts in the chat. I know someone asked about cannabis and if it impacts diabetes in a negative or positive way.
Great question. Cannabis and diabetes, from my understanding, there's nothing in regards to treatment. Cannabis has always been really good from a pain standpoint, but not necessarily to treatment that I know of in terms of, but it's always been good for pain. So cannabis could possibly help with neuropathic pain. So what we're talking about is if you've had diabetes and over time, diabetes can destroy the myelin sheaths around your nerves, and that's what leads to diabetic neuropathic pain, which can lead to ultimately amputations. And so the pain associated with that, cannabis can certainly help with the pain, probably neuropathic pain. That's probably what you're referencing. But that's on down the line, but there's nothing to my knowledge about cannabis treating diabetes.
Okay. And then Ambria, are there any, I see there's a lot. Are there questions or just comments in the chat box?
Yeah, we actually have a couple of questions in the chat. There's one question that says, I have lost a significant amount of weight and have about 20 to 30 pounds to go. When should we go see a doctor to have our medication reassessed?
Well, I mean, I think what you do is before you take your medication, you have the goal of where your weight would like to be, where you would like and you continue. It sounds like you're moving towards that goal being achieved. So as you have your doctor's appointments, you kind of see where you are and see from a medication standpoint any adjustments. The great thing about diabetes is you can remove towards type 2 diabetes remission. So I think someone asked a question about that. You know, your A1C, you know, always keep in mind that, again, less than 5.7, pre-diabetes starts at 5.7 to 6.4. Diabetes is 6.4 and higher. Your goal is to keep, I always tell patients, you want to make sure it's below 7 because your likelihood for microvascular complications decreases by 34% when you keep that A1C below 7. So that's always a thought process, keeping that A1C below 7. So I don't have a higher likelihood of eye problems, kidney problems, nerve problems, and cardiovascular problems. So that's why you want to really think that way. And then also A1C below 5.7 in the 5.6 area, that's kind of normal. So understanding that number is important. And again, that's a 3-month average. Your A1C represents your 3-month average. So I would say have that conversation with your doctor. And as you monitor your improvement, monitor your weight, and just make sure that your goals are aligned. And it may be that you can get off medication, get off diabetes medication once you achieve your goals, and then maintain a healthy diet and exercise.
Okay, and next question, Ambria.
Next question is, what is the relationship between type 2 diabetes and strokes?
Oh, yeah. Well, so I want you to think of it like this. Once you start the process of, there's this relationship between cholesterol, blood pressure, and blood sugar levels. Okay. And, you don't want high cholesterol, you don't want high blood pressure, and you don't want diabetes, because what happens is when you have all three of those together, as plaques begin to form in your bloodstream, they collect and they can form clots over time. So you think about it, when somebody has a heart attack, they usually say, you hear this term blockage, right? They have blockage that's within their vessels, their blood vessels. And so, well, if you have those arteries and those plaques and those blockages that go in the brain, that's when you can have a cerebrovascular accident, or cerebrovascular CVA, which is a stroke, a cerebrovascular accident, which could, and then you have a transient ischemic attack, which is a mini stroke. So those things can happen because of clots of cholesterol, excess blood sugar, leading to, as you guys remember, I was using that example of the darkening of a banana or rusting of metal. That is the process of oxidation. Okay, you have oxidation. That's what happens when, over time, when those blockages form, and then it can damage the lining of your blood vessels, leading to other problems, weakening of blood vessels as well. And that can contribute to issues of cerebrovascular accidents, strokes, things of that nature. So that's why blood pressure, keep it down. Blood sugar levels, keep it down. And cholesterol levels, keep it down. Because they all are the triumvirate that can contribute to clots, leading to those types of problems, heart attack problems, problems with blood vessels that can lead to strokes as well.
Yes. So do we have another question in the chat, Ambria?
I think that's all the questions that we have.
Okay. So I note the time, like time always flies. It seems like we have a lot of time, and then before you know it, it's the top of the hour. But want to mention that we put the link to the survey in the chat. So please click on the link to provide your feedback about the session for today. And you'll also get a follow-up email, but please, if you can fill it out right away, we'd love to get your feedback on the session today, what other topics you'd like to hear about or learn about, and what we can do to continue to improve upon what we're currently doing. And so I did want to ask one more question. You mentioned something about side effects of other medications could contribute or lead to diabetes. I never thought about that, but you do hear all the fair balance that's part of a commercial about any medication, and all the side effects or things that you need to be concerned about should you take the medication. So can you talk a little bit more about that? You mentioned
Yeah. Antipsychotics. So specifically Zyprexa. And I worked for the company, Eli Lilly, at the time when they started to see in the data that there was a higher likelihood of individuals getting type 2 diabetes that were on certain antipsychotic drugs, and specifically that one. So, just you wanting to be aware that as you treat, if you have a predisposition that's just to diabetes, maybe because of your family genetics, that's just something to be aware of. So that's an example of a drug where that could be a problem. And remember, steroids, right? Steroids have if you look at the structure of steroids, it's very similar in structure to glucose, sugar. I mean, they look very similar. So if this particular structure So in medicinal chemistry, we used to always look at the structure of glucose and look at the structure of steroids. You know, they're very similar in their structure. So they can certainly contribute to you know, leaning someone towards diabetes over time. And then they're powerful. Some of the steroids stay in your body longer, so they can have that effect that leans towards being sugar-like, and then leading to a predisposition for full-blown diabetes. So it's just certainly something to be aware of.
Okay. Well, once again, thank you so much, Courtney, for being with us today, for devoting 5 hours of your time in your life over the last month or so to help build awareness and understanding and education around diabetes and how to more effectively manage your diabetes if you're dealing with that, and how to prevent diabetes from occurring in the first place.
I think it was 3 months, Rhonda. We started in April, so it's 3 months.
Okay, so 3 months, yes. Like time flies, right? When you're having fun.
When you're having fun, that's right.
Yeah, that's
Yep.
right, yes. So just want to respect everybody's time and let everyone know we have an event coming up next Saturday, June 24th. That's related to our non-toxic Black Beauty project. So we want to, build awareness around the toxic chemicals that are in hair care and personal care products that are specifically targeted to Black women, or I shouldn't say targeted, but made for Black women. So if you're in LA, please come join us at Faithful Central Bible Church next Saturday. You can register on our website under the events tab. We're going to have a lot of fun. We're going to give away nice prizes and gifts. And if you come, you have a chance to win up to $500. So tell everybody that you know who might be interested in attending or interested in learning more about this topic. And then also we will be starting a series that is specifically focused on pre-diabetes starting later this month. So we will be posting information about that also on our website. So please stay on the lookout for news about that. And you can always keep in touch and stay in the loop on what we're doing. You can join us on social at Your CBHN, on Facebook, Twitter, and Instagram. You can connect with us on LinkedIn at California Black Health Network. You can always support us by joining in on the campaign for Black Health Equity. Our ultimate goal is to improve life expectancy of Black Californians. So join us in the fight to do that. So thank you once again for attending today and have a great afternoon. Thanks a lot.